am pleased to present my research. My study is a scoping review that explores a very important question. How do children with learning disorders process information and emotions? To answer this, I decided to connect three fundamental pillars of psychology. Executive function, the brain's control center, theory of mind, our ability to understand others, and learning disorders. In the scientific community, we often study these topics separately. However, the goal of my research was to join and see if these three constructs are correlated in the current literature. Introduction. To start, I want to explain why this research is important. Many children with neurodevelopmental disorders face significant challenges in their social and behavioral lives. This often makes it difficult for them to build relationships and interact with others. My study focuses specifically on school-age children and teenagers between 6 and 18 years old. The central concept, theory of mind. The fundamental concept of my research is theory of mind. This is our ability to understand that other people have different thoughts and feelings to us. In my review, I explain that these skills doesn't grow in isolation. It is connected to several key areas of a child's development. First, emotion. It is linked to how a child attaches to their parents and how they learn to self-regulate their own feelings. Second, language. There is a very strong connection here. Basically, better language skills help a child pass false beliefs tests and understand complex social situations. Third, executive function. This is engine of the brain. To understand others, a child needs specific skills like inhibitory control, stopping an impulsive thought, perspective taking, seeing things from another person's point of view, cognitive flexibility, the ability to adapt to new rules. The core idea. In short, my introduction showed that language, executive function, and theory of mind are not separate boxes. They are all interconnected. In my work, I investigated what happens to this connection when a student has a learning disorders. Does a problem with brain management also lead to a problem with understanding others? What do we already know? In the scientific world, we have many studies on disorders like autism, deficits in social cognition, and ADHD, problems with empathy. The gap in my research. This study were my starting point. I noticed that while we know a lot about autism and ADHD, we have very little research about specific learning disorder. The big question. We know that skills like inhibitory control, perspective taking, and language are all interconnected. My review asks, how do these connections work in students with learning disorders? This is a topic that definitely needs more attention. Method. To conduct my scoping review, I mapped the existing research using two main databases, PsycInfo and PubMed. The search. I focused on up-to-date articles published between 2008 and 2021 in both English and Italian. The criteria. I selected studies about children and teenagers from 6 to 18 years old, strictly focusing on learning disorders and excluding other conditions like schizophrenia. The process. After a double screening of title and abstract, I selected the most relevant paper to analyze. Results. After the screening, I analyzed 7 articles conducted in Italy, Turkey, and China. 3 main areas emerged. Executive function. The research confirms that children with SLD have significant difficulty in managing their brain resources. They struggle with planning, organization, and working memory. One study showed that children with dyslexia use too many cognitive resources just to read, which leads to brain fatigue. Theory of mind and emotion. Children with SLD struggle with emotion recognition. They find it difficult to identify facial expression like happiness or anger, possibly because they have lower focused attention. Behavior and environment. These issues affect daily life. Parents report problems with self-regulation, and students often face difficulties with their peers and classmates. In short, the 7 studies show that a learning disorder is not just about reading or math. It is a complex situation where weak executive function, like planning and memory, and difficulties in theory of mind, recognizing emotion, work together, making school and social life more challenging for these teenagers. Discussion. What does this all mean? My review reveals a clear link between brain management and social understanding. The main findings show that executive deficits like planning and memory and social challenges like recognizing emotion go beyond the classroom. We also saw that the family environment and peer relationship are essential factors. A learning disorder is not just about reading or math, it is a complex connection between cognitive function and social skills. Future support should address both academics and emotional needs. Conclusion. This research showed that there is a significant gap in the scientific literature. It was not possible to find articles that investigate all 3 topics together: theory of mind, executive function, and learning disorder. Most of the analyzed studies focus only on executive function. Only one article studies the connection with emotion recognition. For this reason, further research is necessary. It is important to analyze the relationship between brain management and social skills to provide better support for students with learning disorder. Thank you for your attention.
Thank you. Thank you for the invitation. I'd like to present the first Italian study on the impact of climate change on the mental health of young people, people aged 18 to 35. We ran this research last year, and we published on the Journal of Health and Environmental Research last year. It's the first study made in Italy about these topics. What our aim? We know that climate change is increasingly recognized as one of the major public health challenges of our century. And while its effects on physical health are well documented, growing evidence suggests that climate change also has important consequences for psychological well-being. Our study explored how climate change affects mental health of young Italians, and we focus on anxiety, psychological distress, future orientation, and also the everyday functioning. So why to care about mental health? The psychological consequences of climate change have received considerably less attention than, for example, the health impact, the physical health impact on environmental health impact. However, climate-related stressor can influence, we know now, emotional well-being through multiple pathways, including direct exposure to extreme weather events, concerns about the future, perception of environmental degradation, and uncertainty regarding personal and social individual prospects. Young adults may be particularly vulnerable because they are building their identities, planning their futures, and making important educational, professional, and family decisions about a very uncertain future they perceive. This our background. Previous international research, not in Italy, unfortunately, but in many other countries, has shown that climate change may be associated with anxiety and worry about the future, psychological distress, feelings of helplessness, loss of control, reduced life satisfaction, and increased risk of mental health difficulties following, for example, extreme weather events. In Italy, research on these topics remain limited, despite our countries, unfortunately, has an increased exposure to heat waves, floods, droughts, and other climate-related hazards. Our study objectives, the study we designed, was aimed to answer three main questions. Does climate change affect the mental health of Italian young adults? And which psychological dimensions are most strongly affected? And how do eco-anxiety and direct experiences of extreme weather events can contribute to psychological distress? The aim so was not only to measure symptoms, but also to understand how climate-related concerns shape the everyday life and the future expectation of young people. Our methodology was a mixed method design. We saw combine quantitative and qualitative approaches. And we collected 3,600 participants aged between 18 and 35 years from all the regions of Italy. The quantitative component assessed variables as eco-anxiety, climate-related distress, generalized anxiety, psychological distress, life satisfaction, future orientation, existential meaning. And the qualitative component analyzed thousands of open-ended responses describing emotional and personal experience related to climate change. We use for that specific software, MaxQDA. The questionnaire, evidence-based questionnaire, and all validated in Italy that we use. Also, we put two open questions in the questionnaire. When considering the topic of climate change, what emotions do you commonly associate with it? Was the first question. And what is the impact of anxiety or distress related to climate change and environmental issues on your daily life functioning and in what specific ways? This open question we analyze with MaxQDA software. Participant characteristic, I told you 3,600 young adults. There is no other research in Italy with this dimension of sample, and 61% age between 19 and 25 years, and 39% over 26 till 35, from northern, central, southern Italy and Ireland. And what really was interesting for us is that 80% of participants reported to have had personal experiences of extreme weather events in their area of residence. It means that in Italy we are really deeply affected by climate change consequences. So in Italy is no more a distant scientific phenomenon, it's a direct and lived reality. But we managed to do correlation analysis that reveal consistent relationships between climate-related variables and mental health outcomes. So higher levels of eco-anxiety, climate distress, and climate-related impairment associated with higher psychological distress, higher generalized anxiety, lower life satisfaction, lower levels of hope regarding the future. So climate change concerns, worried are linked not only to emotional reaction, but also to indicator of psychological functioning and psychopathological outcomes. And we also have the possibility with our statistic to show that extreme weather events matter, because the role of direct exposures to extreme weather events was very important. The young adults who reported experiencing such events show higher levels of climate-related distress, eco-anxiety, psychological distress, and existential concerns. So the personal experience may transform climate change from an abstract issue, environmental issue, into a psychological significant life event, and even a psychopathological outcome. We managed to also build a structural equation model, SEM model, that provided important information about the mechanism underlying psychological distress. And this structural equation model showed that personal experience of climate change, extreme weather events, and eco-anxiety contribute directly or indirectly to psychological distress. You can see the graph here on the left. And these effects are mediated by variables as pessimism and climate-related impairment. But what we find most important in our research, that we discover a key mechanism, the loss of purpose for the young people. The model suggests that eco-anxiety may contribute to a sense that life has become less meaningful or less directed toward future goals. And this loss of purpose acts as a central mechanism linking to climate-related concerns to broader psychological distress. The climate change appears capable of affecting not only the emotional well-being, psychological well-being, but also a very important existential dimension of the human experience, mainly in young people. And which emotions do young people associate with climate change? Our qualitative analysis, the open questions, show that most frequent answers were concern about the future, anger and frustration, helplessness and resignation, sadness and sorrow. and only a minority, very minority of respondents express indifference. So we found out that climate change evokes a broad spectrum of emotional responses, and many of these responses are future oriented. And this future anxiety is the dominant theme because this concern is the most prominent concern and worry that we found. Participants express very frequently fear regarding future living conditions, uncertainty about long-term prospects, concerns about environmental alteration, and doubts about the future safety and stability of the society and so of their future life. So the future appears to these young people a sort of psychological core around which many climate-related concerns are organized. And the impact on daily functioning was also very strong represented in our research. Most frequently, the young people reported that on the daily life, they were feeling distress in psychological well-being, so a decreasing of psychological well-being, that the climate change worry, preoccupation, and eco-anxiety was affecting eating and consumption habits and social relationship. And also, any of them also reported that climate change preoccupation was affecting concentration, productivity, future planning, personal decision of these young. We also created a hierarchical subcodes model, but our article, it's open source, so you can just enter in the website of the journal and just download it, and you will find all this representation included in our article. What we also found out that the young people reported a change in their behavior. So, for example, reduced consumption, more sustainable purchasing choices, vegetarian or vegan dietary changes, and a greater environmental awareness, and also lifestyle modification aimed to reducing environmental impact. And all these findings in the answer of the young, these 4,000 young people in Italy suggest that climate anxiety may function not only as a source of distress, but also driver of a good behavioral change. But there is also an impact on social relationship because we found that the climate change was influencing interpersonal relationships in young people. They frequently describe disagreement with family members, frustration to people perceived as indifferent, conflicts regarding environmental responsibility, feelings of social isolation. And so climate change, we see that it's not only an individual issue, but becoming a relational and social phenomenon. We found also geographical differences across Italy, and participants from southern Italy and Italian islands reported higher anxiety, greater distress, more existential concerns, and lower life satisfaction. So the geographical context may shape the psychological responses to climate change, probably reflecting a bigger exposure and a bigger socioeconomic vulnerability of South Italian compared to North Italian. What implication for our mental health practice? We, after these discovers, these findings, we have to increase attention about climate-related issues in clinical, educational, and in community settings. So we have to monitor more the climate-related psychological distress. We have to support coping strategies, promote hope and future orientation, and address these feelings of helplessness, purposelessness, and so to develop more preventive intervention to the population. Our conclusions is that our research, our study provides some of the strongest evidence that to date in Italy regarding the psychological impact of climate change on young adults in Italy, and demonstrate that climate change is associated with anxiety, psychological distress, altered future expectation, changes in behavior, and existential concerns. Most important, studies suggest the psychological consequences of climate change extend beyond fear and worry, affecting how young people imagine their future and how they define their goals and construct meaning in their lives. So thank you very much for your attention.
The topic I would like to talk about is an important and challenging issue, both socially and individually, domestic violence. I'd also like to show how neuropsychology-based thinking can be applied in this area. First, I'm going to introduce the questionnaire for experiencing and using violence in intimate relationships, and as a diagnostic tool, designed for a therapeutic practice, and using an example of a selected case. The questionnaire consists of two parts. The first focus on experiencing violence, and second on the use of violence. Also contains four forms of violence. Is the same in experiencing and using violence: emotional, sexual, economic, physical. And examples of behaviors considered to be violence. It's very important to take both perspectives into account, because in domestic violence, the context in which the violence occurs is crucial. Who use proactive or reactive violence, and sometimes mutual bidirectional violence. This is second part, this questionnaire. This questionnaire has limitations. First, it doesn't account for many emerging forms of violence, such as cyber violence, legal abuse, paper abuse, and others. We use interview, and we can also discuss other form of violence. And second limitation is its self-report format, which often triggers denial mechanism in individuals who use violence. When discussing the questionnaire, we must be mindful of these mechanisms. Neuropsychological foundations is very interesting approach to domestic violence. because neuropsychological factors play a significant role in intimate partner violence. Dysfunction is a prefrontal cortex, which is responsible for impulse control and decision making, may reduce an individual's ability to regulate aggressive behavior. At the same time, heightened reactivity of the amygdala can lead to increased emotional responses, such as anger or fear, which may escalate conflicts. Imbalances in a neurotransmitter, particularly serotonin and dopamine, have also been associated with aggression and poor emotional regulation. Additionally, early exposure to trauma can alter brain development, increasing the likelihood of or violent behavior in adult relationships. This neurobiological mechanism interact with social and psychological factors, contributing the complexity of intimate partner violence. Emotions associated with violence are anger, guilt, rage, shame, hostility, fear, disgust. And sometimes we are unable to notice these emotions because they are hidden beneath aggressive reaction. Let me now introduce a case study as follows. A man is 37, residing in Poland, but he comes from England. Diagnosis in ICD-11, mild personality disorder, negative affectivity, dissociality, and ankastia. Narcissistic personality disorder of mild severity, it is in the DSM-5. Alcohol, cannabis, and cocaine addiction. It was a very complicated case. Violent perpetrated, primary, proactive, physical, emotional, economic, sexual, and stalking. The violence was directed toward his wife, children, parents-in-law, and wife's sister. He experienced violence from wife. She used reactive violence against him, physical and emotional. Case study. Continue. A clinical explanation. The man engaged in proactive violence under the influence of alcohol and cocaine, as well as during alcohol withdrawal syndrome. The relationship between psychoactive substance use and aggression is complex and moderated by intrapsychic and interpersonal factors. Some psychoactive substances disinhibit behavioral through their effects on the central nervous system. Others are taken for courage, to reduce anxiety or increase the sense of power. Aggression may also be a desperate attempt to obtain substances or money to avoid withdrawal symptoms. Violence may also arise from the social context of drug dealing and coercive mechanisms. This diagram shows the relationship between fragile self-esteem. Oh, it's a mistake. Should be self-esteem and limited emotional control and the motivation for violent behaviors. Negative feelings are split off from the perception of oneself as a special person, and this dissociation comes into conflict with reality. And after attacked consequences, ego protection, dominance, need for control, and avoidance of responsibility. Um, Motivation for therapy, it is very important stage, and therapeutic process with this man was initiated following the partner's decision to pursue a divorce and her demand he immediately vacate the apartment, which was her sole property. The individual who had used violence exhibited predominantly external fear-based motivation. It is based motivation in this case. This included concerns about divorce and separation, potential restrictions on contact with his children, loss of social status associated with the prestigious location of the former residence, as well as fear of the disintegration of his previously stable self-image and the loss of positive perception of him. His therapy consists of 8 stages. At the beginning of the therapy, this person also recognized the forms of violence used and experiencing in the relationship, referring to the questionnaire which I mentioned previous. And first stage was treatment of psychoactive substance dependence. Second, identification of aggressive and violent behaviors associated with the use of psychoactive substances, along with an analysis of their psychological functions. Third, analysis of harms resulting from substance use, including personal, social, and spiritual consequences. Fourth, rehabilitation and strengthening of motivation to maintain abstinence. Fifth, recognition of difficulties in daily functioning arising from the both personality traits and mechanisms of addiction. Sixth, participation in group therapy for individuals who use violence. Seventh, development of emotional regulation skills and strategies for coping with cravings related to addiction. And eighth, for work on beliefs sustaining violent behavior, including their deconstruction, critical analysis, and modification. Stages of therapy lasted 4 years and include both individual and group therapy. I know that this man and his wife continue therapy in couple therapy. Throughout all stages, the patient focused on identifying his destructive thoughts and beliefs and exploring possibilities for modifying them toward more adaptive patterns of thinking and functioning. We use also the violent thinking questionnaire. It is our second tools used in the work because these tools describe thinking people who use violence. Now I present 6 stages of coherence therapy. Apart from coherence therapy, we also draw a cognitive behavioral therapy, schema therapy, and other approach. Today, I will focus on just one part of this work, changing beliefs as a key element in treatment violence, along with straightening prefrontal cortex process. This is also experiential work in therapy. First stages, it is discover on the symptoms, emotional logic. Goal is understand why the symptom exists from the perspectives on the emotional brain. What this looks like, exploring situations where the symptoms appears, tracking emotional reactions, not just thoughts, identifying implicit beliefs like if I relax, I lose control, or being visible is dangerous. Outcome is a first glimpse that is symptoms is protective, not random. Accessing second stages, it is accessing the implicit emotional schema. Goals is bring the underlying emotional learning fully into awareness. What this looks like, evoking the emotional memory of felt sense connected to the symptom, using imagery, memory, or present moment triggers, letting the emotional through, speaking in this in its own words. Outcome: the client can articulate the emotional logic clearly. For example, showing anger would get me reject, so I must suppress it. Third stage is verifying the schema coherence. Goal is confirm the emotional learning truly fits the symptom. What this looks like, checking whether the emotional through feels right in the body, seeing how it explains the symptoms persistent. Noticing relief of recognition when the logic is named. Outcome is a sense of yes, it is exactly why I do this. Fourth stage is creating a juxtaposition experience. A goal is bring the emotional learning into direct, connected with contradictory but equally true knowledge. This is the transformational engine on coherence therapy. What this looks like, holding the emotional through, I must stay invisible to be safe, alongside a contradictory through, I'm safe and respect when I speak up now. In the same moment of awareness, outcome destabilization of the old emotional learning. Fifth stage is memory reconsolidation. Goal allows the brain to update the old emotional learning at the neural level. What this looks like, repeating the juxtaposition experience, staying with the emotional activation long enough, letting the brain rewrite the implicit memory. Outcome is emotional schema loses its power, the symptom beings to dissolve. And sixth stage, verification of transformation. Goal is confirm the emotional learning has truly changed. What this looks like, testing old triggers, observing whether the symptom still appears, checking for new emotional responses. Outcomes, the symptoms no longer feels necessary. The client experience new freedom, choice, and ease. And to sum up this presentation, I can briefly say partner violence therapy includes several key stages. Identifying who in the relationship uses violence proactively, who use it reactively, or whether the violence is mutual or bidirectional. Understanding the mechanism behind this violence, identifying the circumstances that reinforce of support violence within the family, exploring the beliefs that play a key role in triggering domestic violence. Thank you for attention.
Hi, everybody. Good afternoon or good evening for folks from different parts of the world. I'm Mian, a professor in special education from the University of California, Santa Barbara. It's my great pleasure to present my work here and thank you and thanks the conference for the opportunity. And thank you for everybody who are attending the session and listening to my presentation today. So my talk focuses on naturalistic developmental behavioral interventions, or NDBIs, as culturally adapted evidence-based practices for autistic individuals. I'm trying in this presentation, I'm trying to connect this topic directly to the conference theme this year, healing brain, mind, and society. In this talk, healing does not mean curing autism or making autistic people appear less autistic. Rather, healing means supporting autistic people regarding their communication, participation, family well-being, culturally belonging, mental health, and quality of life. This framing is consistent with recent calls in the literature to move autistic intervention towards person, environment fit, neurodiversity informed support, and quality of life outcomes. Why this topic matters? The need for effective and human autism support is urgent. Recent CDC surveillance data reported that approximately 1 in 31 8-year-old US children were identified with autism spectrum disorder in 2022 across participating ADDM sites. Yet, prevalence alone does not tell us exactly what kind of support is needed by autistic people. Autistic individuals are also at elevated risk for anxiety, depression, social isolation, and reduced quality of life, in addition to their key autistic characteristics on social communications and interactions, and restricted interest and repetitive behavior. Look at some of the recent studies. Horlocks and colleagues found high rates of anxiety and depression among autistic adults, while Van Heest and Gertz show that autistic individuals experience lower quality of life across their lifespan. More recent research on camouflaging also shows link between masking and the poor mental health outcome. Therefore, the key question I think we should be asking here is not simply whether an intervention improves just skills, but whether it improves life as a whole. Over the last few decades, the autism intervention field has made important progress in identifying evidence-based practices. Reviews by Wang and colleagues and Humes and colleagues provide systematic guidance about 28 intervention models that have strong empirical support. However, evidence-based practice does not necessarily automatically mean culturally responsive, socially valid, and neurodiversity affirming, or beneficial for long-term well-being. According to Sandbeck et al. 2020, evidence-based practice has not yet adequately addressed the following issues, such as long-term outcome, adverse event monitoring, social validity, cultural fit, and autistic people's input about intervention goal and outcome. My recent book chapter, Wang et al. 2022, argues that autism interventions research need to move beyond short-term goals, short-term gains, and examine individual and family quality of life, mental health, adverse effects, autistic perspective, and cultural fit. This is where NDBIs can serve as a useful bridge between intervention science and a broader healing agenda. Now let me briefly talk a little bit about what NDBIs are. NDBIs are a family of interventions that combine behavioral learning principles with developmental science. They are implemented in natural setting and rely on child's interest, motivation, and everyday routines. Defining features of NDBIs include shared control between the adult and the child, natural reinforcement, developmentally meaningful targets, objectives, and learning opportunities embedded in play, caregiving, activities, and social interaction. So in this science, NDBIs present a major shift from typical adult-directed intervention towards a more naturalistic and relational model of support. As you can see in this slide, NDBI examples including many different models, such as pivotal response treatment, PRT short name, originally developed at UCSB, where I'm working, by my colleague, Bob and Lynn Cagle. The earlier Start Denver model, developed and implemented at UC Davis. Project Impact, Enhanced Milieu Teaching, Incidental Teaching, and Jasper from Dr. Kazari in her lab at UCLA. The brain dimension of my today's talk is really through the lens of developmental. NDBIs are relevant because they treat development as occurring within natural, emotional, meaningful, and socially rich context. The earlier Start Denver model randomized clinical control trial study showed improvement in autistic children's IQ, adaptive behavior, and diagnostic ASD severity level among toddlers receiving ESDM compared with those only receiving community-based intervention. A later report from Rogers and Darson 2020 also suggested that early intervention may be associated with change in children's brain activity related to social processing. So a larger point I'm making here is that NDBIs do not treat the brain as isolated biology. They place brain development inside the social engagement, motivation, and everyday relationship. Healing the mind. The mind dimension concerns emotional well-being, autonomy, confidence, and mental health. NDBIs have the potential to support mental health when they build on children's interests, the strength, rather than focusing narrowly on remediating their deficits. However, this promise depends on goal selection. If intervention goals pressure autistic children to mask, suppress autistic communication, or just imitate neurotypical social behaviors, then intervention may likely contribute to psychological distress. Research on camouflaging shows that masking is associated with anxiety, depression, social anxiety, and lower mental well-being. For this very reason, NDBIs should promote communication, participation, and agency of autistic people rather than normalization. Healing family. So cultural adaptation is central to my today's talk. Evidence-based interventions are often developed and tested in particularly cultural contexts. So it is risky to assume these models are universally acceptable or appropriate. NDBIs are especially dependent upon culture because they are embedded in family routines, language practices, caregiving relationships, and parent-child interaction patterns. Cultural adaptation involves a planned and collaborative process of adjusting intervention content, examples, language, routines, and delivery while preserving core intervention principles. So there's some studies conducted in China and India show that NDBIs can be adapted to fit local family contexts and caregiving systems. Healing society. The society dimension of my today's talk asks us to consider whether autism intervention changes only the child or also changes environment, expectations, and the system, including community level and societal levels. Neurodiversity does not mean denying disability or rejecting support. Rather, it challenges us to design supports that respect autistic ways of being while reducing barriers to their participation in the community and the society. Lai and colleagues argue that support should be optimized person-environment fit, reduce stigma, and promote inclusion across the lifespan for autistic people. Schack and colleagues argue that NDBIs can be reconciled with neurodiversity when they center autistic perspective and focus on meaningful goals, quality of life, and social participation rather than normalization or compliances. Well, let me now talk a little bit about both promises and limitations of NDBIs as intervention models or systems. The strongest argument for NDBI is that it's a very balanced approach. On one hand, NDBIs have one of the most promising evidence-based among autism interventions. So they're, just like I said earlier, they are naturalistic, child-centered, and developmentally informed. They also hold a promise for generalization, family involvement, and cultural responsiveness. Then, on the other hand, the evidence base still has limitations. Reviews have raised concerns about so heavily rely on parent self-report outcome limited long-term follow-up and outcome, and some methodological weaknesses. Other scholars, such as Sandbach et al. 2020 and Baltimore Butel et al. 2021, have highlighted insufficient adverse event reporting and incomplete social validity assessment. The next generation of NDBI research must ask not only whether intervention works, but questions like for whom it works and what conditions it works, with what risks and with what effect on quality of life for autistic people and their families. Now, to conclude my today's talk, NDBIs are not merely a set of intervention techniques. They can become a broader framework for autism support when implemented in a culturally adapted, family-centered, strength-based, and neurodiversity affirming way. They support the brain by embedding learning in meaningful developmental contexts. They support the mind by promoting autonomy, communication, confidence, and emotional well-being. They also support the society by shifting the intervention goal from fixing autistic people to improving person-environment fit, reducing stigma, and expanding inclusion for having autistic people to be true member of the community and society. The future of autism intervention should not only be evidence-based, it must also be value-based, culturally responsive, socially valid, and accountable to the long-term well-being of autistic individuals and their families. Thank you very much for your listening to my
Ladies and gentlemen, thank you for the opportunity to speak today. It is a great honor to present our work on neurological speech therapy in patients with multiple sclerosis. Today, I would like to share with you a detailed case study that illustrates not only the clinical complexity of dysphagia and dysphagia, but also the real therapeutic potential even in a progressive neurological disease. Introduction. Multiple sclerosis, or MS, is a chronic, immune-mediated disease of the central nervous system characterized by demyelination and neurodegeneration. It affects millions of people worldwide, and it is one of the most common causes of neurological disability in young and middle-aged adults. As this disease progresses, patients experience a wide spectrum of symptoms: motor sensory, cognitive, and emotional. Among these, speech and swallowing disorders are particularly significant, although they are sometimes underestimated in clinical practice. Dysarthria affects approximately 40 to 50% of patients with MS, while dysphagia may occur in up to 60% of cases, especially in advanced stages. This disorder has profound consequences: impaired communication, reduced social participation, nutritional deficiencies, and most importantly, risk of aspiration pneumonia, which remains one of the leading causes of morbidity and mortality in this group. Therefore, early diagnosis and targeted therapy are not optional, they are essential. Aim of the study. The aim of the study was to evaluate the effectiveness of neurological speech therapy in a patient with ataxic-spastic dysphagia, neurological dysphagia in the course of long-term multiple sclerosis. We were particularly interested in whether a structured, individualized therapy program could improve physiological swallowing, enhance speech intelligibility, and positively influence the patient's quality of life. Case description. The patient was a 52-year-old diagnosed with multiple sclerosis 28 years earlier. At the time of assessment, she remained cognitively intact. She maintained logical and coherent communication. However, her daily functioning was significantly affected by neurological deficits. From a neurological perspective, the patient presented spastic paresthesis of the lower limbs, ataxia of the right upper limb, diplopia and nystagmus, sensory disturbance on the right side of the face, fatigue syndrome, and depressive symptoms. Importantly, these physical symptoms were accompanied by reduced concentration, emotional lability, and subjective sense of psychological inefficiency. These factors are crucial because they directly influence the effectiveness of therapy and patient engagement. Assessment tools. To objectively evaluate the patient's condition, we use standardized tools. EAT10, Eating Assessment Tool, score 16, indicating significant dysphagia, DYMUS questionnaire, score 9. Additionally, maximum phonation time 15 seconds, below optimal value indicating respiratory phonatory inefficiency. These results confirm the need to immediately therapeutic intervention. Clinical picture of dysarthria and dysphagia. Before therapy, the patient presented a complex and mixed clinical picture. Dysarthria. Her speech was characterized by irregular rhythm, scanning and explosive speech pattern, reduced fluency, impaired coordination between breathing and phonation. These features are typically of mixed ataxic-spastic dysarthria, commonly observed in multisclerosis due to multifocal CNS damage. Speech intelligibility decreased significantly under emotional stress, which further limited communication. Dysphagia. Swallowing disorder were also clearly present. The patient reported difficulty initiating swallowing, sensation of food sticking in the throat, need for repeated swallowing, choking episodes, and nasal regurgitation during liquid intake. Clinical observation confirmed poor oral control, premature spillage of food and liquids, delayed swallowing reflex, impaired soft palate function. Therapeutic approach.
Yes.
Therapeutic approach. The therapy program lasted 5 months with 1 session per week, 60 minutes, structured home exercises performed daily. A key principle was individualization. Each stage of therapy was adapted to the patient's abilities, fatigue level, and progress. The intervention was divided into 2 main components. First one, dysarthria therapy. Stage 1, respiratory training. We began with breathing exercises to improve lung capacity, extend inhalation and exhalation phases, exchange coordination between breathing and speech. This included diaphragmatic breathing, controlled exhalation exercise, phonation with sustained sounds, lax vox therapy. Why is this important? Because speech production depends fundamentally on controlled airflow. Without stable respiratory support, articulation and phonation cannot function effectively. Stage 2, orofacial and articulatory training. The next stage focused on facial muscle tone, lip and tongue mobility, neuromotor coordination. Technique includes neuromotor facial massage, resistance exercises, repetitive articulatory tasks. This stage was particularly important in reducing imprisoned articulation, sound prolongation, speech instability. Stage 3, phonation and prosody. Finally, therapy addressed voice modulation, rhythm, intonation, speech tempo. Exercise included vowel prolongation, intonation variation, reading tasks with emotional modulation. As a result, speech became more natural, more intelligible, and less effortful. 2. Dysphagia therapy. Dysphagia therapy focused on both functional improvement and compensation strategy. Compensatory technique. The patient was trained in chin tuck position, supraglottic swallowing, posture stabilization, modification of food consistency. And these techniques are crucial in reducing aspiration risk. Functional exercises. Therapy targeted soft palate activation, upper esophageal sphincter function, pharyngeal muscle strength. Key technique included Masako maneuver, shaker exercise, Mendelssohn maneuver. Sensory stimulation. Thermal and tactile stimulation was used to improve sensory feedback, restore swallowing reflexes. Laryngeal elevation. Exercise and manual technique were applied to improve laryngeal movement, facilitate safe swallowing. Results. After 5 months, reduced choking episodes, Subjectively, the patient reported less effort during the swallowing, reduced pain, greater comfort while eating. This is extremely important because dysphagia often leads to fear of eating and consequently malnutrition. Speech outcomes. Maximum phonation time increased from 15 to 19 seconds. Improved respiratory phonatory coordination, clearer articulation, reduced scanning speech. Speech become more stable and easier to understand, especially in longer utterance. Functional and physiological impact. One of the most significant outcomes was the physiological improvement. The patient reported increased confidence, reduced anxiety related to eating and speaking, greater independence. These highlights are important points. Speech therapy is not only about function, it is also about quality of life. Clinical implication. From a clinical perspective, this case highlights several important points. Speech therapists play a critical role in MS management. Therapy must be individualized, flexible, continuously adapted. Early intervention is essential. Education of the patient is as important as the exercise themselves. Conclusion. Based on this study, we can conclude that neurological speech therapy can significantly improve both speech and swallowing in MS patients. Even in long-term disease, functional gain are achievable. Continuous therapy is necessary to maintain results. Dysphagia therapy reduces stress and improves quality of life. Early diagnosis is crucial in preventing complications. Patient motivation and active participation are the key dominants of success. Final remarks. In conclusion, although multiple sclerosis remains an incurable disease, it does not mean that therapeutic intervention is ineffective. On the contrary, targeted, individualized speech therapy can restore essential functions, prevent complications, and perhaps most importantly, improve the patient's dignity and independence. Thank you very much for your attention.
I will be talking about something that's been around for quite some time and been rediscovered by the corporate life, I would say, corporate world, is thanks to its effectiveness when it comes to dealing with corporate well-being. So I'm not talking about pathology. I'm not talking about dysfunctional characters or personalities or situations, but I'm talking about how to improve what we've already achieved so far in the corporate life. For some countries in the world, that's a bit difficult to understand, but especially in the Western Europe, we face an important concept called burnout. Burnout exists everywhere, but I think thanks to the legal system that helps to identify and also to support, there's an amazing surge and increase of people with burnout symptoms, complaints, and even registrations. And the number is overwhelming. So there is something wrong, I would say, with the work. Or maybe things are changing and people are not being able to adapt. Or maybe the work has not adapted itself for today's requirements of the of the modern life. On the other hand, when we identify that there is enough well-being at work, some sort of, there's a remarkable increase of efficiency, effectiveness, decrease of absenteeism. So that's really kind of been documented. And then the turnover. Turnover is an issue, especially in sectors like retail, industry, many parts of the service sector, because of training, retraining, skilling, upskilling of the workforce, which also causes more stress and helps for add to the burnout concept. Very simple solution to create an environment where people can offer their contextual wisdom in a way that really enhances psychological safety and finds kind of a solution to these problems and also improve the whole well-being concept at work. I'm going to use the definition of mentoring as by EMCC, because the issue when I talk about mentoring, traditionally there's the sponsorship model, which is basically a model where the protege is being supported by the experienced mentor to reach certain goals. We're not talking about this. We're talking about developmental mentoring. It's a kind of learning relationship that involves sharing skills, knowledge, and expertise between two people. And those two roles are interchangeable because both party learns from this relationship. It's about developmental conversations, experience sharing, and role modeling. The relationship is inclusive, values the mutual differences. There's a mutual learning, and it's two-way partnership. And these are the key issues when we talk about mentoring in the developmental mentoring sense that really helps the problems I highlighted in the previous slide. Because, it's a mutual learning, it's an inclusive dialogue, and it brings some contextual adaptability, and it really values the differences. So it's in a way, it's really enhanced diversity supported by inclusion. And there are some key issues in order to really highlight based on our research. It's a shared wisdom. So it's about inspiring, not teaching or learning or didacting, especially with the younger generations Alpha, Z, whatever you name it. It's all about giving them a kind of inspiration so that they can build their self-efficacy and confidence in their journey. Listening is a key issue. I used to be a long-term in corporate life, and I don't remember in my early years that we take any training on the listening skills. But especially after the pandemic, we discovered that the listening is a very, very important part to create this safe environment in the workplace. And it also requires cognitive empathy. Unfortunately, in today's world, many people use empathy in the psychological, in the more emotional sense, and it goes to sympathy or antipathy, which doesn't help. So the cognitive empathy is about, like Brené Brown describes it, like when a child cries in dark, the first reflex of the mothers and fathers turn on the light. It's not empathy. Empathy is to be able to have the courage to stay in dark with a crying child. So basically, how you can face the difficulties or dysfunctional beliefs or feelings or emotions of your mentee and making sure that they don't feel alone, they don't feel insecure, but they are in a place where they will grow, they will learn, and they will get out, especially with someone who has contextual wisdom. And then the last issue is not about solving the issue or problem. It's about creating awareness and insight about the issue, the relationship of the issue with the mentee. So these are very basic things, but at the end of the day, the mentoring is based on dialogue. It's not a debate, it's not a discussion. It's not about winning an argument or finding the right or wrong. It's basically creating a dialogue to ensure that there's a non-judgmental transformative communication between two people. And the research shows once people are feeling that they are being heard, listened, seen, respected, they start to deal with their own stress in a more efficient way. And that creates some coping strategies in perspective to their, and new perspectives to face their issues. That enhances the job satisfactions. We have certain studies that really help them. The key psychological needs are really directly linked with the mental well-being and morale at work. A stronger workplace relationship. We have this McKinsey study that shows that one of the reasons why people are leaving their employers are not being able to find caring and trusting teammates, not the company or the boss or whatever, but basically their teammates. It's a shared responsibility now. And it's basically a tacit knowledge. So basically, any company who created this knowledge over the years or generations, this is the best way to pass it to the new generation. So it brings creativity, innovation, and with all together, it really kind of enhances the career and confidence of the people. So we did this study about how to link the EMCC standards for the mentoring programs with Seligman's PERMA methodology. And it really fits very well because at the end of the day, once the program is well designed, it really accomplishes the requirements or the expectations of the PERMA model. But there are some core principles in the way we design the programs. The first one is the reflective practice. It's not about what happened. It's all about what would you do with it. So what's the impact of your experiences on you? And it's not a cognitive exercise. It's also involving all the emotions in the right time, in the right place. The agency, taking the mentee out of the kind of victim psychology and to put them in charge of their lives, their choices, and to be more aware of their perspectives when it comes to facing their issues. As I mentioned, it's about the non-judgmental cognitive empathy, staying in dark, the example I gave you. And it's a present and centered and focused. So it's not about planning the future or curing the past, but it's all about focusing on today, right here, right now. And it's, again, not solving the problem, but enhancing the awareness and bringing new perspectives to the relationship of the person with the issue. And that brings no advice giving in a way. It's basically to sharing an advice in a detached way so that it becomes a kind of inspiration for the mentee rather than a roadmap to be followed. So what about the leadership? It's not a program, it's a kind of culture that we're developing in companies. So that requires a kind of sponsorship and ownership from the top. It really requires the decision makers in the company to embrace this new way of thinking, communications, and the team building in the company. It can be designed in different ways. The literature mentions certain structures, but it could be one-to-one, peer group, or one-to-many, many-to-one. It can be designed based on the purpose on the program. The goals are very important. Rather than being a cliche, to really embedding the goals of the program in the program in the company's KPIs is very important. And preparing the mentees and mentors, but also anyone, any stakeholder of the program in the institutions or around, or understanding or experience, demos and everything, that's really important. And then creating a support system for the management of the company, the program, to learn and to make it better next round. It's not just one season, those programs. They really go on and on and on. So basically, in order to enhance the organizational resilience, and as we are all kind of being aware that AI is here and kind of have an impact on everything, almost everything we do. So we also started to work on how AI would help those mentoring programs. And it does, because at the end of this, it's about feeling comfortable with the unknown and how to bring more open dialogue, reflective practice into your communications. And in that respect, we find good collaboration opportunities there. Mentoring bridges generational, cultural, and background differences. It kind of provides support and advocacy, especially for underrepresented groups. So it really promotes inclusion and belonging in the organization. As mental challenges increase, mentoring creates human connection and meaning that clinical interventions alone cannot replicate. Because before the pathology came in, how can we improve the lives of already functional people? And that's why it really kind of supports the mental health at scale. An organization with mentoring competencies foster collaboration, problem solving, and collaborative approach, collaborative problem solving, contributing to a more harmonious and adaptive society. It's not only stay with the company, it goes to the general borders of the society. So key takeaway, mentoring is strategic well-being intervention, not just HR tool. The PERMA model shows mentoring nurtures every dimension of psychological well-being simultaneously. A transformational dialogue, cognitive empathy, and reflective practice are the core mechanism of the change. An organization that embed a mentoring culture see measurable gains in engagement, retention, and resilience. And in an era of rapid change and rising mental health challenges, mentoring provides a human-to-human connection that makes a big difference in that respect. So basically, that's all I wanted to share with you. And I'd be more than happy to stay in touch and to learn from your work and how we can bring different subgroups, psychological categories and people with certain characteristics into picture and to make the mentoring programs more and more supportive, the well-being, not only at work, but also of the societies at large. And thank you for this opportunity.
Good afternoon, ladies and gentlemen. Thank you for inviting me to this event. I'm trying to hide everything that might hinder the view. Okay. My talk today will be dedicated to the novel anxiolytic. It is a proprietary drug that was discovered, developed, and is manufactured in Russia. This is a relatively rare situation. We get most of the medications, of course, from the international big pharma companies, and this one was invented locally and is widely used because it has been registered for a few indications already due to the randomized and open label studies that were done in the using the international rules. So we may anticipate its registration in some other countries in the future. It's called maritoperdin. It's international non-patented name. The brand name, the trade name is Aviandr. And my today's talk will be dedicated to the two studies that were conducted to test its efficacy and safety in the treatment of adjustment disorders. And the model for adjustment disorders was the COVID-19 infection, because that was at the time that the trials were done, it was the most relevant stressful factor that was very widespread. So maritoperdin is a multimodal drug. It antagonizes adrenergic and serotonin receptors, multiple serotonin receptors. It is a unique drug that has no other competitive drugs with it has unique pharmacology. It's manufactured as a 20 milligram tablets and is included in the international brand books. It antagonizes, as I already said, several receptors of serotonin, so it might exhibit wide therapeutic potential. It has so far been tested as an anxiolytic, but it is also expected to demonstrate antidepressant, anti-amnesic, and antipsychotic properties, which are, if we speak about antidepressant properties, it must differ from the well-known antidepressants, and it must be much better tolerated because of a very selective pharmacological profile. So it antagonizes serotonin, histamine, a little bit histamine, so with a little bit sedation, and adrenoreceptors, and it has much less affinity to dopamine receptors, and has absolutely no different therapeutic properties. It has no GABAergic action and no affinity to benzodiazepine receptors, so no tolerance and dependence issues, which are, at least in Russia, are a problem with many tranquilizer and anxiolytic drugs, and which I think is very important as a neurologist. It exhibits absolutely no cholinesterase potential. Here, tranquilizers which have anti-acetylcholine action are very popular. And are very widely used as sedatives. So, in my opinion, this is a huge benefit of Aviandr, that it shows none of these properties. It has vast clinical development program. Many trials have been already completed, phase 1, 2, and 3. There are still ongoing trials, mostly post-marketing, but some, as I already said, are phase 3 trials for depression, because it is expected to show also very mild and very tender antidepressive properties with a few side effects. Today, I will show two trials that explored its anxiolytic properties, efficacy, and safety of Aviandr using different scales, including depression scales, anxiety scales, clinical global impression, when we ask patients about their opinion, and also cognitive scale, a widely used DSST test. It was a multi-center, open-label, prospective phase 3 trial for 28 days, 4 weeks, and some patients also opted for additional 14 days. And then these patients were followed up for 7 additional days to test for any withdrawal symptoms. Aviandr was administered twice daily, so a total of 40 milligrams. The trial included 109 patients aged 18 to 65 years old, and anxiety was measured with the internationally validated Hamilton Anxiety Scale. The patients, to be included, the patients had to have 18 to 24 points after COVID-19 infection as a model of acute stress, and they were diagnosed with adjustment disorder. The primary endpoints with a Hamilton Anxiety Scale result at day 28, and then in another 7 days of follow-up. And there were secondary endpoints with the proportion of ratio of patients with more than 50% reduction in anxiety, and also the ratio of patients who achieved remission. They had to have a Hamilton Anxiety Score of less than 7 at day 28 and then day 35. Also, of course, safety adverse events were all recorded. On the slide, you can see the dynamics of Hamilton Anxiety Scale results from baseline at day 0 to day 28 and then day 35 after a 7-day follow-up. And you see progressive decline in the level and severity of anxiety during treatment. So patients achieved a mean of minus 16 points after treatment, and Aviandr reduced anxiety by a mean of 69%, which is a clinically relevant result. The 7-day follow-up showed that the positive dynamics persisted after treatment termination. So the effect was prolonged. It did not stop immediately after treatment termination. On the slide, you can see the dynamics of the Hamilton Anxiety Scale. At baseline, they had a mean of 20 points, and after 4 weeks of treatment, the anxiety level reduced to 6 points on the Hamilton scale, which has a cutoff of 7 points. So 6 points is basically no anxiety. It is a normal value. And then this effect improved a little bit more during the week of follow-up and persisted after treatment termination. 83% of patients, this is a secondary endpoint, achieved more than 50% reduction in the total Hamilton Anxiety Scale score from baseline, and 80% of patients, anxiety was reduced to less than 7 points to normal values after a month of treatment. There were other secondary endpoints. So Aviandr reduced asthenia, fatigue in patients with adjustment disorder. There is a special scale for that. The asthenia severity scale is a visual analog scale. Asthenia severity reduced from 58 to 15 points after treatment termination. It is postulated that this happened due to high affinity to 5-HT7 and 5-HT6 receptors. So in the future, if it does show antidepressant properties, this will be a very valuable power that it has, because most antidepressants fail to do that. Aviandr also reduced functional impairments with patients with adjustment disorder measured by an international Sheehan disability scale. It reduced disability across all 3 core domains: work, school, social life, and family life with home responsibilities, in addition to the reduction in the anxiety severity. In this trial, it was shown also that it does reduce depression and improves cognition in patients with adjustment disorder who present with anxiety. In addition to Hamilton Anxiety Scale, it also reduced the depression severity measured by the Mathers Montgomery-Åsberg Depression Scale, and also it reduced asthenia and disability and improved cognition. You see the result on the DSST, digit symbol substitution test, which is a measure of the working memory mostly and executive function in healthy people without dementia. It does measure cognitive function in people with who are supposed to have normal cognition. They do not have normal cognition when they're anxious, and it does improve the results at day 28, and then further improves it after treatment termination. There were 38 adverse events during treatment in 25% of patients. Five adverse events were considered to be treatment emergent adverse events in 3.6% of patients. 2% had somnolence, and 1% had reduced reactivity or increased creatinine or insomnia, which is paradoxical with the tranquilizer drug. So all registered adverse events were mild, fully resolved, and did not lead to treatment discontinuation in any of the patients. So basically, this large trial of a novel anxiolytic drug Aviandr showed that it can lead to a more than 50% anxiety reduction already at 4 weeks of treatment, which is a very short time frame. It induced 50% anxiety reduction in 83% of patients. 80% of patients reached remission. They were not anxious anymore. None of the patients had withdrawal symptoms or daily somnolence. And the general adverse event rate was 1 to 2%. There was another trial which measured efficacy and safety of Aviandr in post-COVID anxiety in the real-world practice, which was conducted later than the first trial. It was a large multi-center observational post-registration study with a treatment period of 6 weeks and a follow-up of 2 weeks after treatment termination. Patients over 18 years old were included. They had to have mild or moderate post-COVID stress reaction or adjustment disorder. And also they were supposed to have normal cognition measured by the Montreal Cognitive Assessment Scale or mild cognitive impairment, so a MoCA result of over 21 points. Just to be sure that they reported their emotions and feelings and filled the questionnaires correctly. 170 patients were included. There were no dropouts during the 6 weeks of treatment and 2 weeks of follow-up. They were young people. Mean age was 44 years old. And 75% of them were women, as it always happens with anxiety. Severity of anxiety and depression was measured by a sign A scored screening over 23 points moderate anxiety, and 45% of people suffered from severe anxiety. Mean depression score was 19 points, mild depression. They had some comorbidities, cardiovascular disease or chronic pain. 81% of them used to use anxiolytics before. The trial was conducted in 8 cities in Russia, in a total of 15 centers. Anxiety dynamics is shown on the slide. It's a Hamilton scale structured anxiety interview. The anxiety reduction was clinically and statistically significant already after 1 week of treatment. The patients exhibited a clinically significant result of minus 26% of their initial baseline anxiety level. Both psychic and somatic anxiety decreased. You can see that on the graphs on the slide. 85% were responders with a more than 50% reduction in anxiety on the Hamilton structured interview after 6 weeks of treatment. 41% achieved remission after 4 weeks, and 72% of patients achieved remission after 6 weeks of treatment, which is very fast. A total of 85% of patients achieved a more than 50% reduction on the Hamilton anxiety structured interview after the study. Aviandr, unlike many tranquilizers and anxiolytics, demonstrated absolutely no behavioral toxicity. Behavioral toxicity is basically mild cognitive or psychomotor impairment, which can be measured during neuropsychological evaluation. It usually measures daytime drowsiness and cognitive status. No significant daytime drowsiness and even a reduction in drowsiness was observed during treatment, and the cognitive status improved. This was shown before during the phase 3 trial and was replicated during this real-world trial at the post-registration level. Treatment emergent adverse events were shown. There were 12 treatment emergent adverse events in 9 patients, a total of 5%. Most of them were mild. 1 was moderate. Fatigue. There were no serious adverse events during the study and no treatment discontinuation due to adverse events. So the drug is very well tolerated and demonstrates very fast anti-anxiety efficacy during the phase 3 and post-registration trials. I thank you for your attention.
Welcome, everyone. My name's Dr. Hussein Abu Rabia, and I'm here currently working at the Chelsea and Westminster NHS Foundation Trust. Today, at the 4th International Conference on Neuroscience and Mental Health, I'll be presenting a case titled A Fatal Triad, Moyamoya Syndrome, Thyroid Storm, and Euglycaemic DKA. To introduce this topic, we must first look at the intersection of two severe conditions: a thyroid storm, which is a life-threatening hypermetabolic emergency, and Moyamoya syndrome, which is a progressive intracranial vasculopathy. The transformation of hypothyroidism to thyroid storm is exceedingly rare. Crucially, in our field, neuropsychiatric symptoms may actually precede overt neurological signs in these scenarios. My objective today is to present a unique and fatal case involving the fatal triad. This triad consists of thyroid storm, SGLT2 inhibitor-related euglycaemic DKA, and acute bilateral cerebral infarcts due to Moyamoya syndrome. Through this case, I will be highlighting critical interface between the neuroscience and mental health. Starting off, here our patient was a 28-year-old female. Her past medical history included anxiety depressive disorder, hypothyroidism between 2018 and 2021, type 2 diabetes, and PCOS. Her medications at the time included metformin, SGLT2 inhibitor, but notably, her levothyroxine had been stopped in 2021. She initially presented with a 1-month history of worsening anxiety and behavioral changes. She was also experiencing weight loss and exhaustion, alongside palpitations, chest discomfort, and sweating. Alarmingly, she had focal seizures involving her left arm, which were witnessed by her family and husband at the time. Upon initial assessment, her vital signs were actually stable. However, her biochemistry revealed thyrotoxicosis coupled with severe metabolic acidosis. This led to a diagnosis of thyroid storm with euglycaemic DKA, which required an ABCD approach to stabilize her initially. Her management required extensive input from the MDT. She was treated with IV fluids, beta blockers, propylthiouracil, iodine, and hydrocortisone. An ECG was performed, and then she was admitted to the ICU. The endocrinology, neurology, and stroke teams were all involved in her care, and a CT head was performed on admission. Unfortunately, she suffered rapid neurological deterioration, and by day 2, her GCS dropped from 15 to around 6 or 7. She developed refractory agitation, seizures, which required intubation and ventilation. Her medical management did continue, and a repeat CT head was ordered. Looking at her neuroimaging findings, the initial CT head showed frontal lobe hypodensities. The repeat CT head on day 2 revealed extensive bilateral frontoparietal infarctions. There was evidence of sulcal effacement and cerebral edema. This pattern here is highly suggestive of Moyamoya syndrome. Here we can see the CT head on admission and at day 2 with the rapid deterioration. Here is the same image with IV contrast. It is vital to understand the neuropsychiatric mechanisms at play in Moyamoya syndrome. Chronic frontal and frontoparietal hypoperfusion leads to the disruption of frontal subcortical networks. This causes executive dysfunction, specifically impaired attention, working memory, and behavioral regulation. This perfectly explains her neuropsychiatric manifestations, including anxiety, agitation, behavioral changes, and seizures. Because often these symptoms precede a radiological stroke, it leads to dangerous diagnostic delays. The pathophysiology of this case was truly a perfect storm. We observe autoimmune fluctuation, specifically a switch from blocking to stimulating TSH receptors. This results in thyrotoxicosis, causing an endothelial dysfunction, vasoconstriction, and hypercoagulability. This significantly increases the cerebral metabolic demand on the background of pre-existing Moyamoya vasculopathy. Furthermore, the SGLT2 inhibitor masks the severity of her ketoacidosis. Now, looking closely at this digital subtraction angiography, it demonstrates vascular hallmarks of Moyamoya syndrome. What we can see is severe arterial narrowing. As you can see, the main artery coming up from the neck, the internal carotid artery, is severely narrowed or even occluded. Because these main arteries are blocked, the brain tries to compensate by growing chaotic tangled network of tiny, fragile collateral blood vessels at the base of the brain to bypass the blockage. On angiogram, this network looks like a hazy, wispy cloud. This is exactly what Moyamoya translates to into Japanese, a puff of smoke. Tragically, the outcome was fatal. The patient developed progressive cerebral edema, leading to brainstem herniation. Neurological brain death was confirmed, and her care was withdrawn following discussions with her family. There are several key learning points to take away from this case. First, acute psychiatric and behavioral changes may signal a catastrophic neurological disease. Second, an early neurovascular imaging is absolutely essential in cases of thyroid storm that are present with neurological features. Third, always consider euglycaemic DKA in unwell patients taking SGLT2 inhibitors. Finally, this case proves that integrated neuroendocrine mental health care input is critical. In conclusion, Moyamoya syndrome can present as a neuropsychiatric emergency. This case is a stark reminder of the brain-mind-body interaction. A high index of suspicion is required to prevent diagnostic overshadowing, and early neuroimages are vital in patients presenting with acute psychiatric deterioration. Why does this matter for psych and mental health? Psychiatric symptoms often may be the first manifestation of cerebral vascular disease. Frontal hypoperfusion can mimic primary anxiety, mood, or behavioral disorders. Diagnostic overshadowing delays life-saving neurological intervention. This highlights the desperate need for integrated neuropsychiatric assessments in acute deterioration and supports early neuroimaging in atypical or refractory psychiatric presentations. Thank you for attending today. I've included my selected references here. I'd also be happy to take any questions. Thank you so much.
Thank you for inviting me. I really appreciate it. Today I will present my PhD study on deep brain stimulation induced changes in the molecular signature of Parkinson's disease blood leukocyte microRNAs. So Parkinson's disease starts years before clinical symptoms appear. And there are several disease rating scales, for example, HOND and DR stage. The clinical symptoms may appear up to 20 years before the disease actually appears. There is another stage called Braak pathology. Parkinson is very prevalent worldwide, and its incidence is also high and prevalence as well. Overall, more than 1 million people cases in Europe, and in the UK the rates are high as well, and the worldwide frequency is expected to double in the next 20 years. This plot shows the numbers in the UK and in other regions as well. So there is an unmet need for development of early and accurate diagnosis methods. Deep brain stimulation is a surgical treatment which improves dramatically the disease motor symptoms. It reverses them. It offered to advanced Parkinson patients and directed to the subthalamic nucleus, and offered only for patients which symptoms cannot be modified by medications. This technique was developed by my PhD supervisor, Professor Chagai Bergman at Hebrew University of Jerusalem, Israel. So my main research hypotheses were that we can observe PD signature in blood leukocyte of patients through mRNA expression profiling. And I profiled both microRNA using small RNA sequencing as well as microRNA arrays. And I complemented the analysis by targets analysis of alternatively spliced targets by splice junction and exon arrays analysis. So DBS not only provides symptomatic relief, but also ameliorates the neuroinflammatory and stress-related processes that accelerates Parkinson. The mRNA changes are accompanied and parallel to expression of microRNAs. In this publication, I did the analysis of microarrays from Parkinson patients' nucleated blood cells, and I found the neuroimmune and inflammatory changes, which are shown here. I did some network analysis on the data, which results is presented here, and the relevant pathways were discovered. Then I applied exon microarrays, and I published this study as well. I took blood leukocyte samples from healthy individuals, age and gender matched to Parkinson patients undergoing deep brain stimulation treatment, and I took the samples both on electrical stimulation and following 1 hour off electrical stimulation cessation. And then the patient stopped taking the dopamine replacement therapy. And I extracted the leukocytes from the RNA using special filter, and then I extracted RNA from the sample and subjected them to exon microarrays. I did statistical comparisons between the different groups of the study, and I complemented this analysis by splice junction microarrays, specific targeted arrays developed by Affymetrix at the time. So I found a number of downregulated alternatively spliced genes, as well as some that were upregulated in Parkinson patients and following DBS. I found inflammatory genes changes, mainly upregulation, but also a few that were downregulated, signaling pathway genes, and I did some PCA classification on the data, and the samples were grouped to the different groups, healthy control shown in green and Parkinson shown in red. Then I did expression maps of microRNA and macroRNA star genes. I mapped the sequenced files to the human genome, and I found significant changes in both microRNA and microRNA star genes. Some were quite highly expressed. We sequenced 3 samples from each group: healthy control, Parkinson pre-DBS, post-DBS, and off-stimulus. Several millions of read counts were obtained, and I did myself the mapping to the human genome and all the statistical analysis myself, some using the solid software and some using MATLAB, my own tools that I developed. And these maps shows the expression pattern of the 2 top ones of the microRNA and the green one of the microRNA star genes. And the right plot showed thousands of counts. For example, microRNA 144 was quite highly expressed. And then I also did mapping of the rest of the data to non-coding genome, long non-coding RNAs, SINEs, rRNAs, allorepeats, SNO RNAs, etc. And I found I mapped only quite a small fraction of the data mapped to these sequences, but on average, I mapped 55% of microRNAs to the Mir base. So here I plot the expression of these non-coding RNAs as well, and the number of matches and mismatches that I found. Then I did differential expression analysis based on total RNA sequencing counts, solid platform, and I plotted the fold change of the genes, the change between Parkinson patients and healthy controls. I filtered to only the genes that exhibited less than 1 count per million in at least 3 libraries. So I analyzed over 300 mature microRNAs and about 80 mature star microRNAs. And I plotted some common dispersion estimation and negative binomial distribution analysis. I found 17 microRNAs that change. Of them, 6 were downregulated. So in total, I used exon microarrays, junction microarrays, small RNA, total RNA sequencing, exon whole blood, another collaborative study on whole blood samples from rapid and fast progressive patients, and microRNA arrays of Affymetrix. I use online tool to plot a cytoscape network. Okay, so this I did the network, and then I did microRNAs, and you can see here the microRNAs that were found as altered, and the network showed the targets as well. So I targed microRNAs binding to 3' UTR, 5' UTR, and coding sequence of selected target genes. For example, FOXP1 changed, and the PITX3. FOXP1 promotes midbrain identity in embryos related to dopamine. And then I did another network on the DBS attenuated altered microRNAs. This is a little bit smaller network, and you can see here the altered microRNAs as well. And again, network that between microRNAs and potentially regulated differentially expressed or spliced target genes. Here I took public available data from superior frontal gyrus of Parkinson patients from data deposited in the GO and substantia nigra, and I took expression profile of genes that I found as altered in my data, immune genes, mainly in inflammatory genes, and plotted the classification map of these genes in the external data set. And you can see mixed expression pattern in the external data set. Some genes were downregulated and some were upregulated in the hierarchical classification. And my supervisor was Chagai Bergman. And then I thank to Dr. Tzvi Israel and Hermona Sorek and David Gridman and other collaborators. I didn't present here some additional data based on the microRNA arrays where I plotted some box plot and expression profiles of microRNAs that found in the microarrays. But I can say here that I found quite a significant number of microRNAs that were altered based on the Affymetrix microRNA arrays profiling of the data. So I thank also the Genomics Center at the Hebrew University and my funding Israeli chief scientist, Tyson Foundation, and Eurosnet Network for Excellence, and Hebrew University of Jerusalem, and other collaborators. So thank you for.
Hi, my name is Abi. I'm one of the resident doctors from Worcestershire Acute Hospitals. Thank you all for joining. So our research done by me and my colleagues is on methylphenidate and its effects on post-stroke rehabilitation. We did a systematic review and performed a meta-analysis of the RCTs. So stroke is like the leading cause of death and disability in the UK. It affects about 100,000 people per year, and it costs the NHS a lot, approximately £30 billion. A quarter of the strokes occur in the working population, and depending on its severity, it may ruin their careers and their support network. So, although there's been significant research in the management of acute strokes and prevention of stroke, the research on the actual rehabilitation process after stroke has lagged behind. Typically involves physiotherapy, occupational therapy, and managing specific complications like spasticity. In this case, there is some new research on medications that can help this rehabilitation period or like promote recovery. Novel drugs like Sanbexen and even glibenclamide are two of the ones being researched that we came across. In addition to those is methylphenidate. So our aim was to actually assess the effect of efficacy of methylphenidate and use in like post-stroke rehabilitation. Our primary outcomes were motor recovery, and secondary outcomes was its effects on mood. With respect to why it might actually work, it's because methylphenidate blocks reuptake of dopamine and noradrenaline, and preclinical studies suggest that it may promote neuroplasticity, like it may increase neuroid outgrowth and provide a structural remodeling that will precede functional recovery. Although these studies are done not on humans, so its application like humans requires like further investigations. Another theory is that it can help with post-stroke diachesis and increase activity of networks that are usually suppressed post-stroke, especially in the prefrontal and sensory motor cortex, and that can help with arousal, attention, memory, and even motivation. So for our search strategy, we gathered publications from PubMed, Scopus, and Central. They were screened blindly by two authors and conferred with a third. We identified 4 RCTs only for inclusion in the final paper. The studies and the intervention, their protocol, and the risk of bias associated with each one is illustrated in the blue table. So the risk of bias tool used was the Cochrane risk of bias 2 tool. And it focuses on if there are any inaccuracies in the randomization process, deviation from the predefined interventions, missing outcome data, any deep variations in how the data is measured, and how the data is actually reported by the authors of the study. So with our results, we split it into motor outcomes and mood. The motor outcomes, we focused on the Fugel-Meyer scores and the NIHSS, the stroke severity score. So With the Fugl-Meyer score, like again, it is we think is more sensitive to actually pick up subtle differences in functional recovery, because it actually ranks each motor movement and sensory deficit and how this is progressed like through the stroke recovery period. The NIHSS is more broad. It's more useful in stratifying people coming into A&E, and it just has rough measures like, oh, is there any arm drift when they lift up their limbs? Is there any aphasia? Things like that. So with respect to the motor outcomes, we did not find statistically significant results except for the study by Grade et al. And it should be noted that this study was flagged up by the bias tool as being high risk of bias. Similarly, but we can see the trends that are in the expected direction for like all the included studies. With respect to mood, we focused on the study by Delbari and al. Showed that there was a significant improvement in mood at 120 days after starting the tafamidate in the post-stroke period. Great et al. Again showed significant results for low mood, improvements in low mood, but then again, it should be kept in mind that this was a study that was flagged up as being high risk. We also extracted some outcome on the side effect profile of methylphenidate. It is worrying because the most common ones include, at least the ones that we would worry about in this population includes hypertension, increased risk of seizures, arrhythmias. But all the included studies did not find any significant differences between the control and the treatment arms. There is some research to suggest that short-term duration of these medications, this medication might not increase or lead to hypertension as compared to long-term treatment over a year. So again, like the conclusion, while the effect size is improved, it was not significant for motor outcomes. There is some evidence supporting improvement in mood. So we're unable to draw any conclusion. It highlights the need for further studies. Significant limitations to this systematic review include the variation between the studies themselves. One was the small sample size, and variations included differences in recruitment as to which patients, what severity of stroke is being recruited, differences in the actual methylphenidate regime. Some of them, if you see on the table, would start a increasing dose of methylphenidate. Some of them have different durations of treatment. And also another limitation is the duration of follow-up. Delbari and all followed it up for 180 days, but the other studies, not so much, just a month. And we also showed that the Fugl-Meyer scale might be a more sensitive in measure of functional recovery and should be prioritized in these type of studies as compared to the NIHSS. The QR code links the references as well as the original study. But yeah, that is my presentation. Thank you all for listening.
Thank you very much for having me. My name's Dr. Hussein Abu Rabia. I'm one of the foundation doctors in the NHS Trust, and I'll just be presenting the same case as before, as a poster version of Moyamoya syndrome. It explores the rare coexistence of thyroid storm, euglycaemic DKA, and Moyamoya following this autoimmune thyroid conversion. The case itself was a 28-year-old female presented to the ED, various different symptoms including palpitations, chest pain, worsening anxiety, left progressive arm weakness, paresthesia, and some focal seizures as well. Past medical history-wise was primarily the hypothyroidism, which was notably stopped back in 2021. She also had type 2 diabetes, which she was managed with metformin and SGLT2 inhibitors alongside mixed anxiety, depressive disorders, and PCOS. Having a look at the initial investigations, we saw that she had a suppressed TSH and a free T4 exceeding 100 parts per millimole. She was in a metabolic acidosis as well, with a pH of 7.29, with significant keto anemia of 6.2, which was quite interesting as her blood glucose was only mildly elevated. Given her SGLT2 inhibitor use, immediately raised concerns for thyroid storm complicated by euglycaemic decay. We initiated urgent management, including fluids, beta blockers, propylthiouracil, hydrocortisone, and iodine. Within 48 hours, her GCS did drop to around 6 out of 15, which required intubation, ventilation, and prompt MDT input from various teams, including neurology, endocrinology, and the stroke team. We can see that her initial CTs from admission and then on day 2, showing the change on the CT head, indicative of Moyamoya syndrome, with that underlying vasculopathy and catastrophically predicted by the thyroid crisis. She developed brainstem herniation, following discussion with the MDT, was classed as neurologically brain dead, and care was withdrawn. At the pathophysiology, it presents the perfect storm. Patients experienced a rare transition from hypothyroidism to thyrotoxicosis, driven by fluctuations in TSH receptor antibodies. The severe thyrotoxicosis increased the cerebral metabolic demand, induced endothelial dysfunction, and promoted hypercoagulability. When superimposed on an underlying previously undiagnosed Moyamoya vasculopathy, this drastically increased her ischemic injury. Furthermore, the SGLT2 inhibitor therapy precipitated the euglycaemic decay despite the near normal glucose levels, worsening her metabolic instability, complicating the initial diagnostic picture. I think the main learning points here would be recognizing the neurological presentation in an endocrine crisis, recognize that the psychiatric or behavioral changes that may acutely represent early neurological compromise rather than a primary psychiatric pathology. Diagnostic vigilance, we must maintain a high index of suspicion for EDK, as well as patients taking SGLT2 inhibitors in the absence of hyperglycemia. And then I believe the MDT input was crucial. A synergistic cascade of metabolic, autoimmune, and vascular dysfunction can lead to catastrophic injury. The prompt MDT involvement and early neurovascular imaging were absolutely critical when patients present with thyroid storm with focal neurological symptoms. Got my references here if anyone would like to read further on, and I'd be happy to take any questions, or you can absolutely email me any further questions about this case, which I think was quite interesting.
Good morning. I hope you have a wonderful day. Welcome to Resiliency Attributes Associated with the Educational Achievement among Students of Color with Learning Disabilities. My name is Diane Cameron Kelly. I'm an Associate Provost for Student Success, as well as a professor at the School of Social Work. The guiding assumption for this presentation is that Blacks and Latinos who are identified as learning disabled, when they are faced with academic difficulties, they tend to overcome that when they have positive self-concept, strong family support, and connections with a supportive community or cultural group. In essence, when these three elements exist for a student who is identified as learning disabled and has a minority status, they would experience academic success. So before we begin, I just wanted to go over the definition of learning disability. According to the U.S. federal statute 94-142 that was put together in 1975, learning disabilities really focus on basic psychological processes involved in understanding or in using language, spoken or written, that may manifest itself in an imperfect ability to listen, think, speak, read, write, or spell, or even to perform certain mathematical calculations. So some of these learning disabilities would include auditory processing, autism, ADHD, speech and language delays. Those sort of things count as learning disabilities. So what is the problem? A number of students in the population of learning disabled are less likely to receive their high school diploma or GED, enabling them to pursue productive work roles or even higher education. A lot of this is attributed to teacher bias, selective education, isolation from mainstream courses. And just so that you know, a lot of schools dealing with this issue have really focused on making certain that students with learning disabilities are included in the mainstream courses. So that's why they have classes that are known as inclusive classes. So a lot of schools are really holding fast to neuro-inclusivity, but many schools have not. So what is the hypothesis of this conceptual model I'm going to present to you today? First, that there are three primary resiliency factors associated with the educational achievement of learning disabled students of color. And these factors are self-concept, family support, or in particular, support from the parent, and access to community and cultural linkages. The focus is on the resilient child. So, who is the resilient child? First and foremost, it's one who can demonstrate competencies with the ability to overcome adversity. They have a strong sense of self-esteem and self-concept. Their families are cohesive, meaning they have strong family bonds. And also the student has access to cultural and community support systems that reinforce the child's social competencies. So when we look at the resilient child, in particular, minority students with learning disabilities, they have stable relationships with their parents who invest in them emotionally, physically, and financially. And then also, they have parents who have good parental efficacy or the belief that one has a positive influence on the outcome of their child's life. So basically, all of this enables a resilient youth to cope successfully in the face of change, adversity, or risk. So this is the conceptual model that I'm presenting today. Basically, when students have an identified learning disability, they need a healthy self-concept, strong family support, and frequent access to community resources. When these three things do not align, the negative impact is academic failure. However, when these three things do align, the positive impact is academic success and educational achievement. So the principles guiding the conceptual model is that students with minority status and a learning disability, when they have positive self-concept, family support, and access to community support, they will experience academic success or educational achievement. The key to this model is the relationship between self-concept, family support, and community success and community resources. If any of these resiliency attributes are weak or negative, it compromises the strengths of the other attributes. So this provides you with an overview of the resiliency attributes: self-concept, family support, and community or cultural linkages. And just in summary, self-concept is having positive self-image, whereas family support is measured by parents' attendance at IEP conferences, the number of hours parents assist with their child's homework, and that sort of thing. And then membership in different community youth groups and religious organizations and community service hours speak to community and cultural linkages. When a resilient youth has high self-esteem and positive self-concept, they have a realistic understanding of their environment. They demonstrate good problem-solving skills, as well as a great degree of empathy toward others. And this is really a high bar for resilient youth who are learning disabled. They have strong relationships with their parents, and they emerge from supportive communities where the value of community is to protect and guide their youth. So in conclusion, the dominant thought guiding the study is that academic excellence or achievement is a skill combining positive self-concept, perseverance, and support from family, as well as the community. And this has been written about and presented on at other venues. But overall, the goal is to transform educational settings so that they are more neuro-inclusive and can demonstrate an openness and willingness to accept the diversity of neurodivergent students. So if you need more information as well as a copy of the article that was published, please feel free to contact me at this email address, and I will definitely send you the article. And then if you have any other questions that are burning for you regarding neuro-inclusivity, neurodivergence, let me know, and I'll definitely answer those questions. Thank you very much for your time, and I hope you enjoy the rest of the conference.